We are broadcasting live. This is our first ever webinar. We're very excited, and our webinar is on race, ethnicity and health outcomes. And I'd like to welcome you all to participate in this. So we have, this is part one of 2 live webinars which are being recorded. So if you're not able to catch all of the webinar today, or if you want to recommend us to friends, it will be available on the SWIFT website, as our speakers have very graciously allowed us to record them and allow the talks to be available at a later date. So the other thing to let you all know, it's been a little while since we've been with you all, is to update you that SWIFT is now a charity. So we are officially registered with the UK Charitable Commission. And so this is a really great way to launch SWIFT as a charity with our first live webinar. So we are going to, next slide, please. We have 3 amazing speakers today, and we are going to first hear from Clare Perkins from Public Health England, who is very experienced in many realms of public health, but is speaking to us today about COVID-19 with regard to Black, Asian and minority ethnic populations in the UK. She'll be followed by also a really well-received and well-known speaker, Sarah Ateyero, who specialises in BAME in Psychiatry and Psychology network, and is going to talk to us today on racial inequalities in mental health care. So Sarah, really looking forward to that as well. And then finally, SWIFT's very own Rageshri Dhairyawan, who's been amazing at organising today's webinar and inviting such great speakers. And Rageshri herself will speak to us on racism and health outcomes and giving us an overview there. So a really packed programme today, and although I've got 10 minutes to do the introduction, I think it's probably best that we move on, and I'm going to now formally introduce our next speaker, Clare. So as I said, Clare is highly experienced in the realms of public health. She's Deputy Director of Health Improvement at Public Health England in the Priorities and Programmes Division, and she's responsible for many different public health programmes, including mental health, cardiovascular disease, work and health, musculoskeletal health, communities and sexual health, reproductive health, and HIV. And we are really delighted that Clare has been able to join us today and to speak on behalf of SWIFT. So Clare, very big welcome and thank you very much. Over to you.
Thank you, and good afternoon everybody, and I'm absolutely delighted to be here this afternoon. I'm going to talk to you about some work that we've done in Public Health England, looking at the data, the impact of COVID-19 on Black, African, minority ethnic communities. The work, I'm going to talk for probably about 15 minutes. I've got 25 slides, but hopefully there'll be lots of time at the end if you want to ask any questions. I'm going to talk about 3 pieces of work this afternoon. The first is some data analysis that we undertook. The second is a review of the research literature, looking at what others have found through analysis of evidence. And the third piece of work we undertook was engaging with our stakeholders and identifying and sort of seeking their views and evidence from local communities on their understanding of the impact of COVID-19. So this work was undertaken in between March and April of this year. The data focuses on around 135,000 cases of COVID, and these were lab confirmed cases. So next slide, please. So I'm going to concentrate on the first piece of work. I'm just going to pull up my own slides on screen because I can't see the ones that that you're seeing on your screen. So if you can just hang on a second. Okay, so we should be on slide 3. And This first piece of work is an analytical piece of work where we had a review of the data on disparities in both the risk of COVID and the outcomes after COVID. So these findings are based on surveillance data that was available to Public Health England at the time of the publication, well, actually the time of the work, so this was in March and April time, and including a number of data sets that we linked the COVID data set to. So, for example, hospital episode statistics. It confirms that the impact of COVID-19 has replicated existing health inequalities and in some cases has increased them. And we're hoping through doing this work that this will really improve our understanding of this particular pandemic, but also will help us in making sure that we respond to it even more effectively in the future. So next slide, please, slide 4. So first of all, looking at diagnosis rates, and what we found was that these increase with age. And the graph you're seeing, this sort of bar chart, the green are males and the red bar is females. And what we found was that among people under 60 years old, the diagnosis rates were higher in females than males. But when we looked at people aged 60 and above, the diagnosis rates were higher in males. So next slide, please. Slide 5. Now, when we looked at where people live who had been diagnosed with COVID-19, so this is 2 maps. The one on the left of the screen is men, and the one on the right is females. And this shows all the local authorities in England. And what we found was that amongst males, there was a 12-fold difference in diagnosis rate between local authorities. So you can see on the left-hand map, and there's a little sort of outset at the bottom of London, you can see quite high diagnosis rates in London, and then sort of scattered around other sort of urban areas, probably in England. And then when we looked at females, there was an eightfold, so there was an eightfold difference in rates among females. So different pattern in females actually, because so you can see up in the northeast of England were the highest rates for females. So if I can move on to the next slide, please. So slide 6. So when we looked at diagnosis rates by deprivation, now this bar chart, you've got the most deprived 20% of local authorities in the country at the top, and the least deprived 20% at the bottom, and the others in between. And what we found was that the most people living in the most deprived 20% of areas in the country were nearly 2 times more likely to be diagnosed with COVID for males, and 1.7 times the rate for females. So quite a stark difference between people living in deprived communities and people living in more wealthy communities. So slide 7, next slide, please. So this shows the diagnosis rates of COVID by ethnicity. So you can see in this chart that the lowest rates were in the white ethnic groups, and the highest were in people in the other and black ethnic groups. And I just mention about the other groups. So the rates in the other groups, this is likely to be an overestimate, and we're doing some exploration of this other category. And this is sort of a quite technical reasons why this shows to be quite high, but it's likely to be an overestimate, and it's to do with how you allocate ethnicity codes between the different sort of data sets that are used to produce the rate here. So I won't go into that, but that's likely to be a false sort of reading there, if you like. But as you can see from the others, that you can see the diagnosis rate the highest in black and British communities. So next slide, please, which is slide 8. So if we look at the death rates by males and females, then what we found was that working age men diagnosed with COVID-19 were twice as likely to die as their counterpart working age females. So really high difference in mortality or death rates by male and females. And between the ages of 40 to 79, the death rates among males were around double the rates in females, compared with 1.5 times. So what we'd see in previous years, if we looked at sort of death rates in previous years, it would be around sort of 1.5 times. But seeing a lot higher differences between men and women. And I'll just sort of pause there really, because we're really not clear what's driving these different outcomes between men and women. And we can sort of hypothesize about different reasons, and there's likely to be sort of different risks in acquiring infections by by sort of different behaviors, or by the sort of different jobs that people are doing. There's probably differences in how men and women develop symptoms, how they access healthcare, how they're diagnosed. And there's probably likely to be, biological and sort of immune differences, which puts men at greater risk. But we don't really know, but that's a very sort of striking finding in the work. So if we go on to slide 9, please. So this shows mortality rates by age, and this is the largest disparity we found. So the largest difference we found was by age. So among people already diagnosed with COVID-19, people who are 80 years or older were 70 times more likely to die than those people under 40. And 70% of the deaths occurred in those aged 75 and over. So age is a really strong factor in your risk of dying from COVID. Next slide, please. Slide 10. So this slide is about inequalities and death rates. So what we found was the risk of dying amongst those diagnosed with COVID-19 was higher in those living in the more deprived areas than those living in the least deprived, and the bar chart that I showed earlier showed that. So the mortality rates from COVID-19 in the most deprived areas were more than double for both men and women. And this is greater than any inequality we've seen in death rates in previous years. So certainly there's been a big inequality in death rates from COVID-19. So slide 11, please. So this slide shows you mortality or death rates by ethnicity. And what we found was the risk of dying amongst those diagnosed with COVID was higher in those in Black, Asian and minority ethnic groups than in white ethnic groups. And in just as a sort of comparison, in previous years, the death rates were lower in Black, Asian and minority ethnic groups than in white ethnic, when compared to white ethnic groups. So there's sort of been a reversal we've seen with COVID than what we normally expect death rates to show. So if we go on to slide 12, please. So in terms of survival, there are various factors which influence survival, such as comorbidities. So when we talk about comorbidities, we're talking about other diseases people may have, which might be cardiovascular disease, it might be diabetes, it might be high blood pressure. But it also might be the chances of survival might be influenced by variation in testing between areas. So the risk of dying following a positive test for COVID-19, as I've said previously, was 70 times higher in people 80 years or older than those under 40. Higher in males than females, we've talked about that. Higher in those living in more deprived areas versus those living in the least deprived areas, and higher in many Black, Asian and minority ethnic groups than the white British ethnic group, and that's up to double. So the work that we did, the data analysis, we adjusted for age and sex and deprivation and region and ethnicity, but we didn't. One of the things we weren't able to account for was the existence of comorbidities, which we think probably has quite a lot of influence over the sort of inequalities that we're seeing in the data. So if we look to other evidence from other studies, that's shown that when you account for things like diabetes and high blood pressure and heart disease, the difference in risk of death by ethnic group amongst hospital patients is greatly reduced. So we do think that an element that we're seeing in the differences can probably be accounted for by comorbidities, but not all the difference. So if we go on to slide 13, please. So just sort of breaking that down, ethnicity. So the risk of sort of dying following a positive test compared with the white British group was twice as high for people from Bangladeshi origin, 1.4 times as high for people from sort of Pakistani ethnicity, and so on and so forth, down to 1.4 times higher for the other black group. And the other ethnic groups were not significantly different from the white British group. So on to slide 14 for me, please. If we just actually, let's pop onto slide 15. So I'm going to talk next then. So that was the data, the piece that we undertook. So the second piece of work we did was the stakeholder engagement exercise, and we talked to, or rather, Professor Kevin Fenton. I didn't go to all the meetings. I went to a couple of them, but talked to over 4,000 stakeholders from a range of backgrounds, and these included people from across the UK. From the community and voluntary sector, from faith groups, from local government, directors of public health, professional groups, people in the private sector, mental health organisations, academics, think tanks, and really the key objectives were to check out what people's experience has been of COVID, and to identify what people's current concerns were and what people think should be the priorities for action, and to really identify those opportunities for both individual and collective action. And then the other piece of work we did, the third piece, was the rapid literature review, which we did in collaboration with the National Institute for Health Research. So if we go on to slide 16, please. So in terms of the literature review that we did, so this is looking at any evidence produced that's been published by academic organisations, internationally, as well as from this country. And what we found, that other literature tells us that that BAME groups are more likely to be tested and to test positive, that they have increased risk of death associated with COVID-19, and that ethnicity and income inequality or differences are linked, associated with death from COVID-19. So similar to the issues that we found in our own data analysis, and that individuals from BAME groups are more likely to live in overcrowded housing, work in occupations which place them at increased risk of exposure to the infection, and more likely to use public transport when travelling to work. So again, increasing the risk of exposure to the infection. And also the literature told us that individuals from BAME groups may be less likely to seek care when needed, maybe because of previous experience when seeking of sort of racism or stigma, and also maybe less likely to speak up when they have concerns about personal protective equipment or testing. So may feel less likely to, or feel less confident in asking for the protection that they need to do their jobs properly. So moving on to slide 17 then. So this slide's quite busy, but it summarises, and I'll just go through them each in the last few slides that I've got in a little bit more detail. But there were 5 major themes which emerged from our talking to 4,000 people around the impact of COVID-19 on ethnic different ethnic groups. So the first theme was the impact of long-standing social and economic inequality. Really that COVID-19 has exposed existing inequalities in our society. The second theme in red below is the increased risk for groups of exposure to COVID-19, and particularly staff working in frontline roles, people who use public transport, people who live in multiple occupancy homes, maybe overcrowded homes. The third major theme that arose from our conversations was increased risk of complications and death from COVID-19. That could be probably is made worse by having multiple long-term conditions. So I've talked about diabetes and heart disease and high blood pressure, mental health, and that really came through really strongly. We did talk to quite a few mental health stakeholders, so people with serious mental illness as well really increased the risk of sort of complications and death from COVID-19. The fourth theme that came out was around racism, discrimination, stigma, fear, and trust, and that really came out very strongly in the work that we did. And the fifth theme was really was about what we need to do to move forward on this. So I'll just go through those in a little bit more detail. So slide 18 then. So main themes from stakeholders. The first is long-standing inequalities have been exacerbated by COVID-19. And there was a quote, "We have deprivation that is not new. This is an ongoing issue." So people felt really strongly about this. The second theme, increased risk of exposure and acquisition of the infection. Particular people who are key workers using public transport and live in multiple occupancy households. And there's a quote here, which I'll just read. "BAME workers are significantly more likely to be reliant on public transport than white people. More must be done to recognise, safeguard and protect our vital frontline workers. We must take greater care of those who take care of us and our loved ones." The third theme we talked about is increased risk of complications and death from COVID. So I just mentioned the higher rates of multiple long-term conditions, mental health, poorer uptake of prevention services, and the importance of risk factors such as diabetes and obesity and heart disease. So next slide, please, slide 19. The fourth theme was racism, discrimination, stigma, fear and trust, and this came across really clearly in the work. That one of the factors in this that people might be presenting late for treatment, they might not have the same access to personal protective equipment, that occupational risk assessments aren't being carried out, and that we absolutely need, faith and culture plays a really important role in building communities, and we really need to rebuild trust. The fifth theme, moving forward, and what our stakeholders clearly told us, that we need to act now. We can't wait for, of course, more research is needed. Of course, this was a snapshot, and we've got much more data now and we can do more analysis, but we don't need that to act now. We know what needs to be done. And our stakeholders have called for cross-government action, sustainable change, communications that are culturally and faith specific. So, when we do health promotion, campaigns, and some of you might have been aware of the Every Mind Matters campaign that we did in Public Health England, but we spent quite a lot of time making absolutely sure that reached every community, not just certain communities, by co-producing producing with the people that we want to engage with through our communications. And there's a quote from somebody which said, "It's important that we reframe how we work with communities. We shouldn't wait for the data reports before taking action, but should be thinking now about what to do differently." So just coming on to the last few slides now, the last slide, slide 20. So there were a number of recommendations which came out of all those pieces of work and which are being taken forward by various organisations, but the overall responsibility for taking this forward is by the Equalities Minister, Kemi Badenoch. But the first recommendation was we must absolutely mandate really good ethnicity data collection and recording in NHS and social care data collection systems, including death certificates. So it's not good enough at the moment. There's a lot of missing data fields, and unless we record it accurately and 100%, then we're not going to be, we won't be able to know, we won't be able to sort of analyse and identify where the problems are and where we need to take action. The second recommendation was about supporting community research, participatory research, so that we can really understand the social, cultural, structural, economic, religious and other determinants, and to develop the solutions. So making sure that where we're trying to understand problems, that we involve the communities who are experiencing those problems, and undertake research with people and not to people. So the third recommendation was improve the access, experience and outcomes of NHS, local government and integrated care systems services. So including doing health equity audits to make sure that all government services, we make sure that everybody has equal access. That we have equity in workforce and employment, and we rebuild trust. The fourth recommendation is to accelerate the development of culturally competent occupational risk assessment tools for a variety of occupational settings. I won't say any more than that. It's quite a complicated issue. But the fifth recommendation was about funding, developing and implementing culturally competent COVID-19 education and prevention campaigns in partnership with local BAME and faith communities. And that's again that point about making sure the message is right for the right audiences. And one message, one size doesn't fit everybody. We absolutely have to make sure that we get those right. And we reflect everybody in the communications that are put out. The sixth recommendation was accelerate efforts to target culturally competent health promotion and disease prevention programs. I've talked about that for non-communicable diseases, which is your heart disease, your diabetes, obesity, etc. And the last recommendation was to ensure that the COVID-19 recovery strategies actively reduce inequalities caused by the wider determinants of health, so things like housing and work and employment, to create the long-term sustainable change that's needed. So I'm going to stop there. I've probably gone over my time a little bit. Hopefully we've still got some time for questions, but thank you for listening to me, and I'm really happy to undertake questions now, or very happy for you to email me at a later stage. So thank you.
Thank you very much, Claire. You're well within your time, so thank you so much for such an amazing, comprehensive talk. And I think what's wonderful is the combination of qualitative and quantitative data, which really, I think, highlights the issue. So it shows us not only in numbers what the problem is, but also the experiences that people have whilst the UK is experiencing the COVID pandemic. Can I ask, Claire, so you're very experienced in the realm of public health. I know, obviously, we are now all familiar with the findings of health inequalities, particularly with COVID, for BAME. Were you surprised by the findings when they first came out? And what was the main kind of surprise for you when you were doing your own work? Was there anything that really you weren't expecting?
So I think yes. The answer is I was surprised. Yeah, definitely. I expected, I guess we all expected that there would still be inequalities in the data because there already are. But the fact that the inequalities have been exacerbated, have widened through the pandemic is pretty shocking, I think. And so I think, yes, we have been, it has taken us by surprise. And it's really, really important that we understand the reasons for this so that we can tackle it. But yeah, we're surprised, and definitely, I think it's been a real call to action.
Absolutely. And I think, I mean, certainly from Swift's point of view, we had planned to have this seminar in June. So we were kind of, I guess, in some ways slightly ahead of the game in that we were already looking at health inequalities or health outcomes in the context of race and ethnicity. And I'm just thinking now, obviously Black Lives Matter, and there've been huge campaigns throughout the country here and obviously in the US. Just really, this has heightened things for people and really brought out the differences that people are feeling by having skin of a different color. And I'm wondering, how do you feel that if you were to conduct this research again, following, the big publicity associated with Black Lives Matter, do you feel that there might be any change? Are you hopeful that there might be change? Or do you think, despite it being 2020, we are still really stuck with a long way to go?
So I think we've been thinking. It certainly has prompted us as an organisation in Public Health England to look both internally at ourselves and our organisation and how we treat our staff and our Black and minority ethnic network of staff, and how we recruit, and thinking about how can we become a role model as an organisation, as a big employer of staff. So I think that it's really, and I think across the public sector, I think that if we all role modelled some of this, we could really make significant change, because the NHS is the largest employer of people in this country. So I think we can all role model that. And then certainly we're also looking outwards for the services that we provide to absolutely make sure, by conducting equality impact assessments, health impact assessments, to make sure that we understand where the risks are of inequality, and that we actively tackle those. Now, I think there are things that we can do quite quickly, and there are things that are going to take a lot longer. So if we're talking about the sort of entrenched inequalities that we have around employment, and around sort of housing and deprivation, and that take a longer time, obviously, to tackle than things like making sure that we have ethnically diverse recruitment panels, and that those sorts of things that you can that are quite easy to change. So and for a long time, Public Health England, we've been really conscious of all our health promotion campaigns about really targeting. So certainly working in sexual health and reproductive health and HIV, we're doing a lot to absolutely target the people that we know, the communities, the vulnerable communities that we want to work with. So I sort of think we've done a lot, but we've still got an awful long way to go. And I think society has got a long way to go, definitely. And it's definitely a time to reflect and do things differently. And hopefully, Kemi Badenoch has taken up the sort of challenge, and going forward, we'll see significant change. That's my hope.
Excellent, good, and ours too. Absolutely, absolutely. Thank you very much, Claire. We're now going to move on. We haven't had any questions online that I can see. So we're going to move on now to our next speaker, so Sarah Ateyero. So Sarah, welcome. So Sarah is Managing Director of the BME in Psychiatry and Psychology Network, which aims to prioritise and advance ethnic representation within the mental health field. So Sarah is highly experienced, having been an assistant psychologist previously within the NHS, improving access to psychological therapies with problems that adults and young people experience in the realm of mental health, with depression and anxiety. And Sarah is also highly active in trying to increase knowledge about the UK mental health system by through her research, through publication, through active campaigning. And she has published within the Psychologist magazine and also the recent wonderful Colour of Madness, which has really had amazing reviews and has been received very well in the literary community. So Sarah, I'm going to hand over to you. Thank you very much to speak on racial inequalities in mental health care. Thank you, Sarah.
Oh, excuse me. Thank you so much, Yvonne. And thank you for that introduction, and also for Swift for inviting me today. I'm really excited to speak on this topic, and it's a topic that I myself am really passionate about and always try to involve in my day-to-day work in the NHS. Next slide, please. So just a quick overview of today's session. What I'm going to cover, I think it's always really helpful to know what I'm going to be talking about, for the audience to know what I'm going to be talking about. I'm going to be going through kind of the issue of racial inequality in mental health, and then I'm going to go and talk specifically about why there are inequalities in mental health care, particularly for BAME groups and also particularly BAME women. And you can see a couple of the kind of key focus points that I'm going to talk about, and I think it's quite interesting, having heard Claire's talk, how a lot of it is the same health inequalities obviously are the ones that persist in mental health. Then I'll go on to talk about kind of recommendations of how we tackle this mental health inequality in the UK, and also talk about kind of what's being done at the moment. So also kind of future recommendations, but current tasks that have been done at the moment. And then lastly, kind of just a summary of everything, and also leave time for any questions that anyone may have at the end of the session. I always want to preface as well the fact that I am going to be presenting evidence, but I'm also going to be kind of, I guess, building on that with my own experience as working as an assistant psychologist and going on to being a trainee clinical psychologist, and the stories that I've heard within my time in the NHS. So it's going to be both evidence-based, but also anecdotal and experience-based as well. So next slide, please. Starting off with what is this issue of racial inequality in mental health in the NHS and broader mental health services. Next slide. So first of all, I'd like everyone who's here today to consider these two quotes and think about whether or not they shock you or surprise you, or if it's something that you're already aware of, something that you're just learning today. For me, I think these two quotes really demonstrate the two extremes of mental health treatment with the UK and in the NHS particularly. From the first quote, you can see the particular demographic, which is kind of white, British, middle-aged women, are more likely to access mental health treatment, including talking therapies from services such as IAPT, which stands for Improving Access to Psychological Therapies, which I'll go on to discuss later on. And then in contrast, from the second quote, you can see that individuals from BAME backgrounds, particularly Black African and Black Caribbean backgrounds, are subjected to kind of the overuse of force via the Mental Health Act, and are sectioned under the Mental Health and detained, often against their will. Now, the Mental Health Act, like I said, is people are detained against their will and they're treated, and it honestly really isn't a nice experience for many people, but these are individuals who are suffering with maybe the most complex and severe mental health disorders, and it's the idea of sectioning is that they're either a danger to themselves or service users are a danger to others, and it's really in their best interest for their health. But the reason I put these two quotes up is that, like I said, I really feel like it demonstrates the inequality we have. You see BAME people presenting to mental health services at the very kind of top, most complex services because of not having that access earlier on, or that's part of the reason. But just thinking about the impact this has on BAME communities, these service users are, when it comes to BAME women who are sectioned, their mothers, their sisters, it really disrupts and can destroy lives sometimes. Now, for me, like I said, these two quotes to start off with is the best way I can encapsulate the issues of mental health inequality in the UK. And I'll go on to talking about kind of why this is the case. So next slide, please. Also, just to touch upon quickly this idea of chronic physical health. So we're all here today because of Swift, and HIV is a long-term health condition. It's a chronic health condition. And it's a well-known fact that individuals with chronic illnesses are more likely to have mental health issues. And this is for a variety of reasons linked to reduced quality of life often, maybe stigma, all those kind of things contribute to this. But as you can see from what I put up on the slides here, clinicians who are aware of the fact that chronic illnesses make you more likely to have mental health issues are really not trained adeptly to be screening for them, and sometimes are not screening at all. And I think that it really kind of demonstrates a lack of kind of commitment to duty of care. If you know an individual has a health issue which makes them more likely to suffer another disorder, we really should be more adept for screening at them, particularly when we have certain groups presenting with physical health issues. So it leads to kind of poor screening for mental health, negative outcomes for individuals who have physical health issues and as well as a mental health issue. So next slide. So thinking about why is there this disparity in mental health treatment for women from BAME backgrounds? Now, the data that I'm going to present today it's kind of reasons for the whole BAME population, not specifically women. Next slide. So first and foremost is poor access. So those who are here today from a non-psychological background, I'm not sure how aware you might be of IAPT, or what it stands for. I've said I think twice already today, but IAPT stands for Improving Access to Psychological Therapies. And this was a government-led initiative introduced in 2008 in order to directly address the mental health treatment gap. Now, the mental health treatment gap is the fact that in Europe, and I'm still including the UK at this point, 27% of the population are affected by mental health issues. And yet research shows that 74% of those individuals never seek professional help for those disorders. And so this was the rationale for IAPT. However, early results from IAPT, and I'm talking 2010 and 2011, so this is 2 years, 3 years into this program being launched across the country. There's an IAPT service in every kind of borough, city, across the UK and Wales. And it showed that there were certain populations who weren't accessing these mental health services. So that included BAME populations and those from older adult groups as well. And there are lots of reasons that have been kind of hailed as to why why BAME groups aren't accessing mental health treatment. However, what I found from my training and in my clinical practice is that the onus is often placed on BAME individuals for not seeking help. Academics and clinicians are taught that BAME as a group are a hard to reach group. And there's lots of stigma in the BAME community, there's lots of shame attached to mental health, and there's a lack of psychoeducation, so there's a lack of knowledge of being psychologically minded. And these are all held as the reasons as to why BAME individuals aren't accessing mental health services. But I really do want to challenge this perspective. While some of that may be true in terms of stigma within the community, I don't think it's fair to kind of position BAME communities who are suffering from mental health issues as a hard to reach group. It is more so that mental health services and clinicians are failing to provide adequate access and support. And from my own experience, there's lots of ways that services can kind of challenge the issue of BAME individuals not accessing treatment when they need. And when I worked in IAPT, I worked in an IAPT in South London, we were really committed to engaging and fostering contact with local communities and insight gathering to make sure that we're better understanding BAME populations in order to shape services. Now, even the term BAME as a term encompasses so many different and diverse cultures and ethnicities. Sometimes we're not doing it justice by grouping what is in fact the global majority into this one term, and there are different strategies that we might engage with different faith groups, different ethnicity, different cultures, and it's really about kind of as services and as clinicians putting in that effort to understand the community that we're trying to serve better, which will then lead to better access to mental health services. So next slide, please. So reduced quality of care. Now this is another issue when it comes to why there are reasons for mental health inequality in mental health services. Now this quote from Gilleece Kunani, who is a senior psychologist and founder of Race Reflections, which is a fantastic resource for anyone who's interested in mental health. The quote says, "I, as a Black woman, I'm more likely to be prescribed psychotropic medication than to be offered therapy. My chances of being coerced into psychiatric care if I'm in distress are still much higher than the average, and I'm less likely to want to engage in mental health services." Now, notice she puts the term psychiatric care in inverted commas, and I believe that was in reference to kind of being sectioned under the Mental Health Act and what that experience is like for individuals. As I mentioned, being sectioned is not a great experience. It's another form of trauma. You're removed from your family and friends in a very strange environment. And the treatment approach on inpatient wards are very biological. Service users are administered medication up to 3 times a day, more if they're presenting aggressively or if they're refusing treatment. And there's this kind of over-sedation that happens. And going back to my earlier point that individuals from BAME backgrounds are more likely to be sectioned under the Mental Health Act, it really highlights kind of the reduced quality of care that BAME individuals who do seek help are receiving. And one thing I want to talk about is what has been done to kind of improve this or improve the rate of detention that's happening amongst BAME communities. Now, back in 2005, the government launched a project called the Count Me In census, where they were looking specifically at ethnicity data of inpatients and mental health patients treated in the community across England and Wales. Now, in 2005, evidence showed that BAME individuals were more likely to kind of enter the mental health system via the being sectioned, and there was an overrepresentation of BAME individuals who were sectioned under the Mental Health Act. And so there was this commitment to actively trying and put in places and plans to reduce the rate of detention amongst this group and try and serve the community in a different way. Now, in the 5 years that the Healthcare Commission were actively trying to reduce the disproportionate number of Black people detained under the Mental Health Act in psychiatric hospitals, I'm really sad to say that nothing changed. Now, in the last census that was taken in 2010, Black people were still 50% more likely to be detained under the Mental Health Act and enter the mental health system via police referrals and restrained and forced to take medication. So in summary, it's really evident from the data that I'm providing that there is a racial bias and discrimination that plays a huge part into these detention rates, and that is what contributes to the inequality in mental health care that we have at the moment. Next slide, please. So thinking about the other end of the mental health system, so, it's fair to say that kind of psychiatric hospitals and being sectioned is kind of a smaller proportion of individuals who are receiving mental health treatment. I want to think about the most basic level of mental health care that is available in the UK on the NHS for common mental health disorders such as anxiety and depression, disorders again which are often more comorbid with chronic health issues such as HIV, epilepsy, heart disease, all those long-term health conditions. And earlier I mentioned that IAPT is an initiative that was launched in 2008. Now, its predominant mode of treatment is a form of therapy known as CBT. That stands for Cognitive Behavioural Therapy. This is based on the premise that our thoughts, behaviour, and actions and feelings are all interacting to maintain mental health difficulty. There are practical steps that an individual can take in order to address this. Now, a key finding, as you can see from the data on the screen, is that earlier on, in IAPT, BAME people were underrepresented. We weren't getting referrals to IAPT services to receive the care that we needed. This means that GPs and primary care clinicians who were trained to screen and spot mental health difficulties were not referring people from BAME backgrounds. Now, in order to counter this, what happened is IAPT services introduced the ability for individuals to self-refer. You could directly kind of fill out a form or call the IAPT service and say that you'd like to receive an assessment. But now thinking about what happens when BAME people attend IAPT services for treatment. Now, the data here shows that we're less likely to complete treatment, we're less likely to reliably show improvement, and less likely to achieve full recovery. And the question is why? And from my experience and from the research that I've done, it really is evident that services are not culturally responsive. Treatments offered, such as CBT, are often not acceptable for BAME communities and they're not culturally adapted. For example, a crucial element of CBT is this concept of focusing on the individual. on the here and now, which for many BAME individuals is not acceptable, as their distress is within the context of family, culture, community, and reflection on the past is often key. And so often you find BAME individuals saying that CBT didn't work for me. And furthermore, CBT is a very literature-heavy treatment. You have many handouts, written activities, homework that you have to read, and often this material isn't translated. It's only available in English, or many service users or many services aren't able to access interpreters. So again, that's another barrier for BAME individuals from accessing the treatment that they might need. And these are just few examples of how services are currently failing BAME populations. Next slide, please. So lack of representation in mental health services. Now, and this is another way that's kind of the mental health system is contributing to inequalities in mental health care. And this is one that I'm particularly passionate about as a Black woman working in mental health services. So Black and minority ethnic groups make up around 12% of the UK population, yet this isn't reflected in the population of qualified psychologists and mental health practitioners. More importantly, it also doesn't kind of represent the overwhelming number of BAME individuals that present to severe and complex mental health services, as I've mentioned before. Now, on the slide here, you can see that of the 585 students accepted onto clinical psychology training in 2016, which is a route to becoming a qualified clinical psychologist, mental health practitioner who's able to deliver therapy, only 4% were Asian and only 2% were Black. And I really think about what that says about mental health services and the access that BAME individuals have to individuals who might understand their experience. Next slide, please. So this is just kind of further detailed about kind of clinical psychology and its representation at the moment, the application process. So it's a very rigorous 3-year PhD that's funded by the NHS. You can see here the probability of being shortlisted for interview if you're from a BAME background. It's 1 in 9 if you're Asian, and it's 1 in 13 if you're Black. Next slide. And then I think here for me, it's a very good visual representation of the disparity of BAME individuals who are being accepted onto places and white individuals who get accepted onto places. And the same pattern is found among service leads, consultants, and other professionals in high positions within mental health services who at the end of the day are shaping and designing services and saying what gets commissioned and what doesn't. And from my experience working across mental health services is that the majority, where BAME individuals are found, the majority of frontline workers, so in inpatients wards and wards to do with learning disability, you've got nurses who are BAME, support workers who are BAME, care coordinators who are BAME, whilst the decision makers, the higher earners, the doctors, the psychologists, the psychiatrists are often from non-BAME backgrounds. And thinking about why this matters, why is it important that we have a representative workforce? It's the same that Claire was talking about earlier, talking about health inequality. It's about considering how does that affect BAME service users, as well as clinicians' understanding of BAME individuals' mental health distress, triggers, and potential protective factors. Now, this is not to say that racial matching for therapy is the solution, or that Black people want to see Black therapists, or we only want to be treated by people from our own race. That's absolutely not the case. But it's the lack of expert knowledge of different communities, issues that BAME communities might face, or cultural differences in perception or expression of mental health means that services are not being adequately designed for this population. And that's where the real issue is. It creates a culture of ignorance, assumptions, overdiagnosis, misdiagnoses, mismanagement and treatment of BAME people within the mental health services. And that's, I guess, why another contributing factor as to why we have mental health inequality for BAME people. Next slide. So just thinking about what can be done, and I want to talk a little bit about a lot of different things, a lot of suggestions, a lot of things that are being implemented at the moment, and what. So next slide, please. So we've got everything from increasing representation to more radical approaches in terms of decolonizing psychology as a field, psychiatry as a field, and how we see mental distress. And for me, I think I put it in order. So as a Black female practitioner, lack of representation to me is a very key issue. And it's what motivated me to join the BIPP network. So that's the BME in Psychiatry and Psychology network. And the network is a non-profit, and it's really prioritizing advancing the representation of Black and minority ethnic people within mental health field in order to make a positive change. So a lot of the work that is done in terms of mental health and inequality to do with race is service user focus, where actually, as I've shown you today, there's a lot to be done in terms of the field and its representation and the clinicians that are making up those services. And so it's really important to increase the number of BAME mental health professionals that we have, but also the BAME professionals in higher up positions. So like I've said, psychiatrists, psychologists, and the key decision makers. And this includes increasing support for aspiring clinicians through mentorship schemes, access schemes. I was talking recently with a colleague about contextualized offers when it comes to more competitive training programs, and really considering the challenges that a BAME clinician might have faced over their career and to even get to that interview stage. And I know Claire mentioned earlier about having more representative interview panels. That's also a really important aspect. And just to talk a little bit about the work that we do at BIPP, for me, it's been really incredible to be the change that I've wanted to see within my profession. We've put on events that are open to everyone, so not just BAME professional, but events that are teaching what's not taught in the psychology curriculum. So, African-centered psychology and non-Western approaches to treating mental health. We've had events on kind of supporting individuals who are applying for those higher courses in mental health to succeed in their interviews and providing mentorship and support. And we've also, given recent times, had events to reflect and kind of process the collective trauma that's going on amongst clinicians, considering everything that's happening in the world to do with Black Lives Matter and so forth. And then another example of, I guess, increasing the number of BAME mental health professionals is a very specific case I have from the Whittington Health Trust in London. The first London trust to sign up to undertake the NHS Workforce Race Equality Standards Cultural Change Programme. Now, the programme has been designed to help make cultural changes necessary to improve the environment that all staff are working in and ultimately improve the experiences of BAME staff at that specific trust. And I think it's initiatives like this that need to become more commonplace and should be really the rule, not the exception. Next on the screen, I have kind of revision of the Mental Health Act. Now, this is something that I've talked about quite a lot, and many BAME psychologists, academics, activists have all called for a serious review of the Mental Health Act. And there was, in fact, an independent inquiry and review commissioned in 2017, and it was completed in 2018. And the focus of that review was really tackling the disproportionate number of BAME people that were detained. And some of the recommendations from that programme were launching a pilot programme of culturally sensitive advocates in partnership with local authorities to kind of help people who are at risk of being detained under the Mental Health Act, and to identify how best to represent the needs of ethnic minority groups. There's also a recommendation for a partnership between the Care Quality Commission and the Equality and Human Rights Commission to review how they can use their kind of regulation powers to better support equality of access to mental health services, particularly for BAME groups. And there also was kind of the first ever race equality framework, which will help to ensure that mental health care providers working within their local communities improve in the ways in which patients access and experience treatment. And again, going back to Claire's presentation, talking about ensuring that the data on the equality of access is monitored and is accurate. Lower down, we have kind of this idea of breaking away from Western conceptualizations of distress. And I can only really speak to my own experience of this. There's lots of literature around this, but for me, as a Black woman who comes from a Nigerian background, in my household, what is seen as kind of not being emotionally well or distressed is, my mum will ask, have you eaten? And it's really sensitive to food. Food is kind of an identifier of health and wealth and well-being. And there's also this idea of spirituality as well. It's huge amongst BAME communities, from kind of Christianity to Islam. These are all things that mental health services should be not mindful of, but taking into consideration when we are designing services and treatment. And then there's, again, like I mentioned earlier, this idea of community-based healing. I mentioned that BIPP put on a reflective kind of event for BAME professionals working in, well, actually specifically was Black at this point, Black professionals working in the mental health services, to have a space to discuss what they were going through during the time that Black Lives Mattered and how that impacted their ability to care for the patients that they were seeing. And so this approach of community-based healing and moving away from this Western concept of individual and that mental health is the individual's responsibility, and taking a more community approach is really important. Also redefining difference. So framing BAME and being not the majority in a different light and not fitting into the box in a different light. You know, even the term BAME and the fact that it's a kind of a minority status when actually we are the global majority, to me, I find interesting. And also the idea, like I mentioned earlier, disaggregating the term BAME itself, and the importance of collecting data on the different communities that we have in order to meet those community needs. And this Professor Zenobia, who is huge in mental health and has been a huge activist of making mental health a more equitable place, talks about how culture has been politicized, and that we need to move away from this all needs are the same and colorblind approach and really celebrate and acknowledge the differences that we have across our communities. And then finally, I put reducing stigma last intentionally. I truly believe if all the above was consciously implemented, that this last point would really be redundant. There wouldn't be the stigma amongst BAME communities. There wouldn't be a fear of services or a perspective that mental health services are only for the rich or the white or the worried well. It'd be this idea that it will be hard to find a clinician who understands my experience of racial discrimination and how that impacts on my mental health, or the experience that you, or the fear that you might not be able to communicate due to language barriers and lack of interpreters. So for me, I think we often start with reducing stigma and put the onus on BAME individuals to kind of be better at increasing access, but actually, like I've said today, there's a lot to be done at the service level, and I think a bottom-down approach or top-down approach would be better to tackling mental health inequality. Next slide. So that's it from me. I think I've spent just about 25 minutes. I've included some links to kind of places that you can access psychological support if it's something that you are looking to do. And the last two are specifically for people from BAME backgrounds. But I think it's time for me to wrap up and take any questions that you guys might have.
What an amazing overview, and a real, I think for those of us not working in the realm of mental health, I think you've really shown us, you know, a lot of interesting and informative data, but also personal accounts from individuals with quotes that I think really highlight the issues very, very well. We've got questions coming in, Sarah. So just to remind people, on the left-hand bar of your screen, there's a comments bubble. So if you want to use that for questions coming in. So one that's come in is, Sarah, I think you have talked about this, but just to clarify, although Sarah acknowledges the diversity within BAME populations, it's the terminology that we and she and all are using as if it is a single population and community. How do we use language that is better able to distinguish the differences and similarities that exist?
Well, I guess for me, you know, like I said, I'm a big believer in disaggregating the term BAME. I don't think it's fair to have this one word that categorizes a whole complex. I mean, the global majority, like I said. The issue that we're having at the moment, the issue that I've faced in my own research, is that there's not enough data. So like I said, and Claire mentioned earlier, there isn't enough data on the individual groups. So for example, Black Caribbeans, Black Africans, they're two completely, their experiences in mental health services are so different. You talk about Asian populations, you talk about East Asian versus South Asian, all these different communities, there just isn't enough data. And what I've seen at the moment is that we're now starting to conduct those research studies that are specifically looking at Muslim men or Black Caribbean women's experience of postpartum depression, that data is only now being collected, and that's why I think it's quite difficult when we are talking about the racial inequalities that there are in mental health to be more specific than BAME, because the data isn't disaggregated as it is yet, and I guess that's the issue. So we just got to work with what we have at the moment until we are able to use better terminology. But at the moment, kind of BAME is the most accepted term. What I would say is that people, if you're working with a specific population, use that word, and don't say BAME if you mean Black. If you are looking at working with a specific population, then try to conceptualize that and capture the language that best describes the group that you're working with.
Absolutely. And I think we can identify with the points that you're making, Sarah, about the lack of data. So SWIFT was formed because for women who can account for more than half the world's population of people living with HIV, women are hugely underrepresented in trials, and there's big data gaps. So, women are, it's a category, but there are so many different types of women and so many different variables that different women will experience. So absolutely identify with that in the realms of HIV in women, certainly.
Definitely.
Another question that came in was, I work with a lot of asylum seekers who have no recourse to funds and who often suffer from very poor mental health. Have you found that immigration status played any role in lack of access to mental health services?
Definitely. So there are certain categories and criteria that you need to meet. I'm thinking about when I worked in IAP. So like I said, the most basic level of mental health or access to mental health care. I think one of the criteria is that you had to be registered with a GP in the local borough. So already, if you are someone who is an asylum seeker, you might not have temporary, permanent residence or permanent kind of housing. That's a barrier and that's a block. And so, yes, the short answer is yes, there definitely are barriers for asylum seekers. But what I will say is that, again, and maybe it's because of the circles that I'm in and the colleagues that I work with, but I know that there's lots of charities and the specific groups who work on the mental health of asylum seekers. I'm trying to think if I have, none of them roll off the top of my head, but I know that there are services specifically designed to work with people who do not have permanent status in the UK. And so I think it's just a little bit of Googling, but there are services out there, I know that for sure.
Great, excellent. And we have another question, Sarah, that's come in and said, hi, Sarah, excellent presentation, thank you. Given that sadly many non-white people we meet have experienced trauma from repeated episodes of racism, should we be specifically offering mental health support related to trauma care if appropriate?
Definitely. So I think there's definitely kind of literature, and there is trauma-based approaches basically in psychology and psychiatry. There is a very specific kind of way of working with people who are trauma-focused. I think what's interesting is that kind of it's only taken me up until quite recently to identify that racial trauma is something that can be talked about within the therapeutic setting. And I think the way that psychiatry works and psychology works is that that's not something that's seen as something that you could talk about or bring to a therapy session. So now we have this issue of maybe BAME individuals, or I speak from my own experience, feeling like you can't bring that into the therapy room, and then the clinician not having been trained in cultural diversity and racism and the trauma that can come from that, not feeling like they can introduce the topic. It's so powerful when you have non-BAME clinicians who are able to address that. Often BAME clinicians will feel comfortable bringing in issues of race into the therapeutic room. Even in teaching as well, from my own experience, I think one of the most wonderful experiences I had in supervision was my white supervisor asking me how I felt working with a Black Nigerian woman, because obviously we're from the same background. And the confidence in the way in which she said it made me feel comfortable, because she had now allowed me to bring a topic in that I thought was quite important to this individual's treatment. So there's definitely trauma-based approaches out there, and there's specifically racial trauma-based approaches out there. But unfortunately, within psychology and psychiatry, that's the extra work and the extra reading you have to do, and something that you have to do maybe as an ally or non-BAME clinician to actively and purposefully introduce that into your work with BAME individuals.
Right, thank you. And then can I ask it's a practical question, but thinking of in clinics, so we are very aware that there's higher rates of anxiety and depression in people living with HIV, particularly women. And so often in our clinic, we use tools like PHQ-9, GAD-4, GAD-7, and I wonder what's your impression of those in the context of BAME?
Well, there are lots of issues with the PHQ-9 and GAD that have been held for not even just BAME populations, but I'm thinking about, particularly when it comes to chronic issues like HIV, older populations. So older populations have been found to, the PHQ-9 and GAD have been found to be less sensitive and specific to diagnosing individuals from older populations. And then thinking about BAME, not that I can think of any data that comes to mind that's shown it's been less specific, but it's the questions that are asked are quite specific in how your mental health issue might present. And so for older populations and BAME populations, it might not be the case. For example, there's findings that individuals from older adult groups, their presentation of mental distress is more physical. So it's that, have got lots of muscle ache and joint ache, and that might be a sign of depression that is not picked up by the PHQ-9 and the questions that are asked on there. So unfortunately, the PHQ-9, doesn't work for the two groups that I've mentioned. And at the end of the day, they're not diagnostic criteria, they're screening tools. And then you work to kind of ask those more specific questions. But it's tricky, the balancing efficiency and being specific and being able to capture how mental health might present differently in different populations.
And I think that's when clinical skills come in. It's not just about a tool, it's about, and that's where I feel, although we're doing lots of things virtually at the moment, I actually feel face-to-face consultations are hugely important, because body language, where eyes are looking in the room, can really give you a big impression of what's happening for that individual. So I really, believe in face-to-face consultations are very, very important, particularly in the context of people who may have mental health issues in association with their chronic health disorder.
And I think what you've just said about being more holistic, basically, and not relying on this very quick and easy screening tool to determine whether or not this individual has a mental health issue or not. I think that's important, definitely.
Absolutely. Great. I have one last comment for you, Sarah. It's lovely. It's from Rebecca and Biwi from 4M Mentored Mothers and the Network CIC. And Rebecca just wanted to say, I want to applaud Sarah for highlighting many of the things we've been trying to say for a long time. Really great presentation. So Sarah, I'm going to now move on to Rageshri. Thank you so much. So Rageshri, thanks Sarah, is a consultant in sexual health in HIV at BART's NHS Trust, and she's also an honorary senior lecturer at Queen Mary University Hospital. She has a special interest in health equity and is published in this realm. She's a trustee of SWIFT. We're delighted to have her, and also BIVA, who I also work with, delighted to have her there too. And she's also very active in the community organisations supporting NAS, also 4M Perinatal Peer Mentoring CIC, and also NAT on migrants living with HIV. So Rageshri is now going to speak to us in the context of racism and health outcomes and an overview. So Rageshri, thank you so much.
Hi there, you can hear me now. Thank you so much, Yvonne. So I'm going to talk about racism and health outcomes. So essentially, I'm planning to talk about how racism can make people ill. And I'm also going to touch on some of the everyday clinical practices that we use which can further embed racial inequalities in healthcare. And these are clinical practices which we use every day and unintentionally can further entrench these inequalities. So, an opportunity for change. So we've had a lot of discussion about this already, but as we know, lots of people are talking about health inequalities at the moment, particularly racial health inequalities, and that's been due to COVID and also due to the resurgence of the Black Lives Matter movement. And I think this is a great thing. There's a real positive energy at the moment for people to make change. I think talking about racism is an uncomfortable thing to do. And it's encouraging to see that so many people are willing to do that now, because being slightly uncomfortable can make us reflect, and it can really make us think about changing practices and policies. So next slide, please. So, of course, what I want to say is that although racial inequalities have been highlighted by COVID, they've been around for a lot longer. And this is just a list I created of racial health inequalities in the UK. And as you can see, they're prevalent in many, many different areas of medicine. So in here, I cover maternal mortality, prostate cancer, mental health, as Sarah's already talked about, kidney disease, diabetes, hypertension, asthma, and also cervical screening. And it's important to realise that these racial health inequalities are long-standing and are not improving rapidly. And not only do they limit lifespan for Black and Asian people and other racially minoritised groups, they also really impact on quality of life. Next slide, please. So now, what about racial inequalities in HIV? So these are stats from Public Health England, who I do think record them fantastically well. They're very easy to get. So we know that in terms of heterosexual people receiving HIV care in the UK, we know that almost 3/4 of them were from ethnic minority communities. In terms of late diagnosis, we see this highest rates of this in heterosexual Black men, and this is really important because late diagnosis is the most important predictor of HIV-related mortality and ill health in the first year after diagnosis. And in terms of new diagnoses, we're seeing that although the rates are coming down, they're coming down less quickly in Black, Asian and other minority ethnic men who have sex with men compared to white MSM. So we are seeing racial inequalities in HIV. Next slide, please. So why is this important? Well, I think when we think about the UNAIDS targets with 90, 90, 90, and with the fourth 90 being quality of life, we really need to think about who's not reaching those targets. And certainly if we want to reach our target of preventing new HIV infections by 2030, we really want to address these inequalities and close those gaps. But it's not just about targets. Obviously, it's an issue of social justice and human rights. Everyone should be benefiting from the advances that we have in HIV care. You know, there should not be a health inequality. Next slide, please. So this is quite a complicated diagram, but I found it really useful actually. And this shows the pathways in which racism can affect health outcomes. So I'm going to spend a bit of time going through it. So starting on the left, you can see where it starts with racial discrimination, and it actually shows different forms of racism and how they can affect health. So at the bottom, it's got assault. And this is a type of racism that's interpersonal. This is the more obvious type of racism where someone is verbally or physically abused, and it can cause long-lasting mental health problems, and of course can cause physical injury. And this diagram also shows structural racism well. So at the top it says denial of goods, resources or services. So this is due to the uneven distribution of wealth that we have in this country and many other Western countries, and globally in fact. And it means that Black people, Asian people and other ethnic minority groups are more likely to live in persistent poverty, to be unemployed or work in low paid or temporary employment. They're more likely to live in high density and poor quality housing and in areas with high air pollution, have less access to healthy food and green spaces. And all these things can affect mental health, can affect physical health, and can make it much harder to make healthy lifestyle choices. And I think that's a really important thing when we're in clinic, when we talk about improving lifestyle with our patients. It's really hard to tell, if we're telling someone to lose weight because of their liver or for other reasons, for example, we're telling them to lose weight, but it can be difficult, especially if you can't afford healthy food, for example. So we just need to think about that when we talk about lifestyle modification. What are the other things going on in someone's life which makes it harder for them to follow our advice? And then going back to the diagram, you can see it also talks about decreased quality or access to healthcare. And that's something that Sarah talked about, and I'm going to talk a bit more about that later. And of course, if you have less access to healthcare, or if your healthcare is not as good quality, that's going to impact on your physical and mental health as well. And then it talks about psychological stress. So this is a really important thing. So there's increasing evidence that experiencing racial discrimination on a daily basis, and this may not be overt, can make living life harder. So everyday life can just be a little bit more difficult if there's all these racial microaggressions and barriers in many aspects of life. And this everyday racial discrimination can cause chronic stress, which can lead to mental health problems. And this can more likely that people might use negative coping behaviours such as overeating or smoking. There's also increasing evidence that regular exposure to racial discrimination is a chronic stressor that chronically increases stress hormones, impacting on physical and mental health. and this can cause wear or tear to the body, like a form of premature aging. And researchers in the United States call this the weathering effect of racism. So there's increasing evidence about this, and it will be really interesting to see if this work's being done in the UK as well. So next slide, please. So I just wanted to talk a bit more about access to healthcare, and I think this has definitely been touched on by Sarah before. So talking about how we make healthcare hard to reach for some people. So not providing information in the right languages, not providing interpreters, and not providing resources that are culturally specific. And Claire talked about this earlier, not involving the community enough in the planning or delivering of our services or evaluating them. And we really need to think about our specific clinics and think, what are we doing that is making it hard for people to access us? And I think this is particularly important this time with regard to COVID, which may make things worse. Next slide, please. So this is a photo of a demonstration. So this is Doctors Not Cops, which is an activist organisation made of healthcare professionals who are protesting against the hostile immigration policies of the government, especially with regards to charging migrants and data sharing. And there is lots of evidence now that charging people for healthcare does deter them from seeking healthcare, because they may not be able to afford it, or they may worry about coming into health services and then being reported to immigration authorities or being deported. They may also worry that their data is being shared with the immigration authorities, and we know that is a founded fear, because that is what the NHS has been doing until relatively recently. There's research that shows that especially migrants living with HIV, they've been put off from attending for care. And this is particularly the case for my and many so around what healthcare they're entitled to, and language barriers, and of course financial barriers may compound this. Next slide. So I just wanted to put here the definition of institutional racism. So this is a phrase that has been around and used since the late 60s, and was used by Lord Macpherson in the Stephen Lawrence inquiry at the end of the 90s to talk about institutional racism within the police force. And the definition is, institutional racism is the collective failure of an organisation to provide an appropriate and professional service to people because of their colour, culture or ethnic origin. It is seen in processes, attitudes and behaviour which amount to discrimination through unwitting prejudice, ignorance, thoughtlessness and racist stereotyping which disadvantages minority ethnic people. I think it's really important that institutions do reflect upon their practices and look at their outcomes and see if there's anything that they are doing or not doing that is impacting on ethnic minority communities. And I worry that there are some practices within the NHS that do this. And an example of this is, as I just mentioned, is the hostile immigration environment and charging for care. Next slide, please. And I also wanted to talk about something else that can have a big health impact on our patients. So I want to talk a bit about unconscious bias and who is and isn't credible. So the institutional racism definition mentions stereotypes. And when we talk about unconscious bias, that based on stereotypes that we hold within our own unconscious means that we may treat certain groups of people differently. And we know that unconscious bias from healthcare professionals can have a huge impact on health outcomes. So I've just put a study there by Hoffman and colleagues, and this is quite a famous paper on unconscious bias. It's researched in the US and some in the UK that Black people are routinely given less pain medication than white people. And thinking about the reasons of this, so this study on unconscious bias asked healthcare providers about their views about prescribing analgesia. And what they found was they said that they thought that Black people felt less pain. And the reason for that was because they felt they had thicker skin with less nerve endings. And they also thought that because Black people and other people of colour were more likely to be drug addicts, that care had to be taken when prescribing opioid medication. So these are really dangerous stereotypes, which means that people suffer from inadequate pain relief, and thinking about the other ways in which unconscious bias can affect people's experience of healthcare. So we know, I've used a credibility deficit, which I've learned relatively recently, and it's a term from philosophy which talks about who has the credibility to be listened to and who is believed. And it does seem that Black people and other people of colour have less credibility. They're not listened to and they're not believed. And this is also the same particularly with women. And I put two examples on the slide of, for example, there's a news item about delays in endometriosis diagnoses. So the average time to diagnosis for endometriosis is 7 years. And that's related to the fact that women will go to their doctors and talk about the painful periods and be told that that's just not so. They're not taken seriously. They're not referred for ongoing investigations. And I've also put bits about the recent news about the vaginal mesh scandal. And again, a recent review of this showed that that people thought that the women were complaining and it was just women's problems. So again, they weren't seen as being credible. They weren't listened to or believed. So next slide, please. So talking about stereotypes, that paper on unconscious bias talked about Black people having thicker skin and less nerve endings, and essentially talking about how they had different bodies to other people. So where does that come from? So to really understand why some healthcare providers might think this, I think we need to go back in time, and we need to think about where race and racism comes from. Next slide, please. So where does race come from? So European scientists and philosophers started to categorise people into races in the 18th century. And in 1735, Carl Linnaeus, who was a Swedish botanist, who was already well known for categorising other living things such as plants and animals, divided people into 4 races. And he did this based on their appearance and also on how he thought they behaved. So he ranked them. So he categorised them into 4 different categories, and not only did he categorise them, he also ranked them. So he put white Europeans at the top, who he felt they were the most beautiful, the most intelligent and the most good. And he put Africans at the bottom, who he felt were not as beautiful and who he described in his own words as being crafty, sly, lazy, cunning, lustful, careless and full of caprice. And each of the races were given different attributes to do with their appearance and to do with their behaviour. So next slide, please. So this ranking is really important because it meant that from the kind of white European ideal, people were ranked lower in terms of their value and their worth. And the lower ranked races had less worth and were less human. And it's not really a coincidence that this all happened in the 18th century and later on. So this was the time of vast European colonial expansion, and large parts of the world were being taken over and exploited for their resources, including their people. And by saying some races were less human, it was easier to justify carrying out atrocities such as transatlantic slavery and genocide of indigenous populations. I just wanted to mention here, I put it in brackets about HIV 1, 2 and colonialism. Colonialism may have also been quite an important factor in how HIV spread globally. We know from where we see people living with HIV 2 that it does closely match the former Portuguese Empire. And there is increasing evidence that HIV 1 may have come from the Congo and spread out of there due to Belgian colonial practices under the leadership of King Leopold. So it's interesting to see how something that's happened such a long time ago has so many long-lasting effects in so many different ways. Next slide, please. So I wanted to talk here about exploitation and mistrust. The racial hierarchy that I talked about and the belief that races were different biologically was of great interest to European physicians at the time. And lots of physicians and scientists wanted to do experiments to see if bodies were different. So for example, the practice of measuring the size of people's skulls to see whether that was linked to their intelligence was done, and other practices such as robbing graves, to get the bodies of enslaved people in America, to do essentially to do dissection and to look at anatomy to see whether their bodies were any different. And this feeling that some races were less human than others and of less worth meant that it was easier to experiment on them and exploit them. And I put here the Tuskegee syphilis trial, which is of course one of the most famous trials of medical exploitation, and one that we all know very well in sexual health. So just for people who don't know, I'll just briefly talk about it again. So this was when Black people in America were given syphilis without their knowledge, and they were followed up over decades to see the long-lasting effects. And they also followed up the partners of these people and their children who were born with congenital syphilis. And even during the trial, when penicillin was found and it was found to cure syphilis, these people were not treated. So they're followed up for decades afterwards, despite there being adequate treatment. And that's really why this trial is the basis of our good clinical practice training and ethics training and research. But of course, there's so many other examples of unethical medical experimentation and exploitation, and I won't be able to go through them now, but I would recommend reading a book called Medical Apartheid by Harriet Washington, which talks about this in much more detail. It's also really important to realise that much of our medical knowledge, much of our knowledge of drugs comes from this dark place. And in the middle, I put this book, which I would highly recommend, called Breathing Race into the Machine. And this is about how the spirometer was developed to measure lung volume. And it was developed by a physician called Samuel Johnson, who thought that he was a slave physician. So his practice was to experiment on enslaved African Americans and compare how they performed to white people. So that history is very interesting, and it also talks about how when he found that enslaved Africans had less lung volume than white people, he assumed that was because of innate difference, so that Black people generally had less lung volume than white people. But of course, we can think of many other reasons why slaves might have less lung volume, perhaps due to the fact that they worked in very harsh conditions, were not well nourished, etc., etc. So, you know, that's a very interesting read, which I would recommend as well. And on the right, I just wanted to show a picture of Marion Sims, who's also known as the father of modern gynecology. And he tested his new surgical techniques on enslaved women. And again, he often didn't use pain relief or not enough pain relief. And this was, again, due to the belief that Black people were different, had different bodies and didn't feel pain. So I think when we talk now about how we can reduce health inequalities, there's a lot of talk about how some communities don't trust us. And I think reasons from that, from the things that I've just described. And this memory of mistreatment can be passed down through generations. So when we're working with communities of colour, we really need to think about how we can build trust. And I think that's particularly an issue now at the moment when we're looking to trial vaccines for COVID. So next slide, please. And I guess the other thing that's important to think about when we think about how people have different values is around eugenics. So eugenics is the practice of improving the quality of the human race by encouraging people seen to be of higher stock, so more intelligent or beautiful, to reproduce, and stopping those to see of lower stock, so those disabled, mentally ill, of an inferior race or class, or of a different sexuality, from reproducing. And this originated in England, although its popularity was also very wide in Europe and in the US. And it was invented by Francis Galton, who went to UCL, who was a professor, and he was the cousin of Charles Darwin. And as I said, it was very fashionable in the 20th century. Marie Stopes, for her work advocating for contraception and family planning, was a very well-known eugenicist, and she advised contraception as a way of controlling the lower classes from reproducing. She even disowned her own son because he married a woman who was short-sighted, and she just thought that, well, if I have a grandchild who's short-sighted, then that's not good enough. So she didn't feel he was improving his lineage in any way, so she disowned him. And that's a really important point about the history of family planning and how some of it may have come from some eugenicist ideals, and we always have to think about, when we think about reproductive justice now, we need to think about how we need to make sure we're not harking back to old eugenicist views. Eugenics was taken on by the Nazis in the Second World War on a much wider scale, and after that it was obviously much less popular and denounced. But eugenic laws continued well after World War II, and there were still lots of forced sterilisation programmes. So ones were going on in the US till the 70s, in Sweden and in India. And just on the right there, I put just a poster campaign about ending the forced sterilisation of women living with HIV, which we know has been happening as well, and has been documented in over 31 countries around the world. So something we still need to keep an eye out for. Next slide, please. So I've just quoted one of my favourite authors, Gary Young, who has written here that race is a nonsense, but a very real nonsense. So hopefully what I've showed you is that race is a social category and there's no biological basis for it. And actually we know from the Human Genome Project, which mapped the whole human genome, that there's no genetic basis for race either. So it did show that obviously between different populations there were genetic differences, but they didn't match racial categories. And actually when they looked at races, they found there was more genetic diversity within races than between them. Another thing which makes it clear that race is social and not biological is that categories of race have changed over time. And a good example of this is in the US. So when people were moving to the US, initially Irish people and Italians were not classed as being white. And the reason for that was it was felt that their behaviour wasn't becoming of white people. And it was only over a period of time when people thought that their behaviour had improved that they were allowed to be classified as white. So it's very much a social category. And in fact, the impact of people being divided into races is very real. And this is the real nonsense that Gary talks about. The impact is obviously racism, and that has very real disadvantages for many people globally. Next slide, please. So I want to talk a bit more about the misuse of race as a biological category, because I think this is something that we use every day in our clinical practice. Give an example of that, which in a minute. This New England Journal of Medicine article was published very recently, and it actually listed 13 examples of where we used race and ethnicity in clinical algorithms. And it details the impact of using race and ethnicity that they have on health equity, so how they might be damaging. So when we clinicians use race quite poorly in clinical practice and in research. So this study, which I've just written here by Boker-Billman, looked at, I think, 900 publications, and it found that in most of them, race and ethnicity was very poorly defined, or if defined at all, and quite poorly collected by clinicians and researchers. And of course, in many studies, what race a clinician or researcher may say a participant is may not be the same racial category as the patient self-report. So that may be a factor as well. And I think it's important we look at genetics, but we need to think about ancestry. So that is essentially the genetic makeup of a family, so what you inherit from your biological ancestors. So that's important, but we should remember that race is actually a poor proxy of ancestry. And if we're going to look at genetics, we should look at ancestry specifically. Next slide, please. So I'm going to use kidney function as an example of how we misuse race and ethnicity as a biological category. So when we measure kidney function routinely, we check someone's blood creatinine. So the test is for creatinine, and then using a calculation, looking at the patient's age and their gender and the creatinine, we estimate how well the kidney is working. And we basically do a test called the estimated glomerular filtration rate, and we use this as a proxy of kidney function. And this EGFR is actually really important clinically. So we use it to make many decisions. So we use it to dose medications. And in HIV, for example, it tells us when we should take people off TDF and put them onto TAF, or how we dose lamivudine. It can tell us when we can or can't use contrast dyes when we're doing diagnostic scans. It tells us when a patient is referred to a kidney specialist. It tells us when dialysis is used. And it tells us when a patient can be listed for kidney transplant. So it's a really important measurement which has a lot of clinical use. And we're also taught to correct the EGFR for race or ethnicity. So, for example, we are told that if our patient is Black, then we should times the result by 1.2, so raising the EGFR. And a higher EGFR is better because it means kidneys are functioning better. So where does this come from? This comes from the assumption that Black people have higher levels of creatinine in their blood, and creatinine comes from muscle. So the assumption is that Black people have higher muscle mass. And I think that's something we probably just need to think about for a second. Do all Black people have more muscle than everyone else? I mean, thinking about patients in clinic, you know, would an 80-year-old Black woman who's quite frail, would she have more muscle mass than a healthy 30-year-old white man? I'm not sure that's the case. So it's quite an assumption to make. And actually the evidence on this high creatinine is very conflicting across studies. And again, who are Black people? You know, who's Black? Is someone who is African-American the same as someone who comes from a country in sub-Saharan Africa, or someone who's Black British? And what about people who aren't Black? What about Asians or people from the Pacific Islands? Where do they come in on this equation? And what is someone's mixed race? So they have one Black parent. Does this mean that we use skin colour as a marker of being Black? And if so, is this very scientific? So it really relies on us trying to make a decision about whether someone's Black or not, and then using it to correct our EGFR calculation. So what's the impact of this? So when we calculate for race, we're timesing by 1.2 and we are increasing the EGFR. And that means that it can sometimes mask poor kidney function. And this results in delayed care and advanced kidney disease. So it has a real impact on patient care. And actually, this is something that's beginning to change. And I think what's been really interesting this year has been seeing all the medical student activism, which has been mainly in the US, but has definitely spread to the UK. And hospitals, SCs in the US are now speaking to their nephrologists, and they're getting rid of the race correction factor. So I think it'll be really interesting to see if that happens here. And I think it will, you know, it will go a long way towards improving health equity. So this is, I think, is a good example of how we use race as a biological category in everyday medicine, and how by doing that we are further embedding racial inequalities. Sorry, next slide, please. I've just talked through that, so we can go to the next slide. Thanks. So I really wanted to talk a bit about HIV and just think about how we use race and ethnicity here. So I want to talk a bit very briefly about pharmacogenetics, because it's definitely not my area of expertise. But essentially, pharmacogenetics is a study of how people respond differently to drug therapy based on their genetic makeup. And at the moment, I think lots of people are looking towards the goal of personalised medicine. So we know that drugs affect people in different ways. So how do we know which drugs will affect people differently? So how can we tailor therapy so people get the best you know, side effect profile from their drugs and know that they'll work? So we've got a few examples in HIV. So for example, with efavirenz, we know that for some people with certain genotypes, that they metabolize the drug less quickly than other people. And this means there's high levels of efavirenz, and it means that people are more likely to have CNS side effects. We also know that with the HLA-B5701 genotype, that this can cause a Bacavir hypersensitivity, it's associated with a Bacavir hypersensitivity. So that's why we check every patient who may start a Bacavir for this, and if they're positive, we don't. So we're already thinking about personalised medicine in HIV, and that's a good thing. I think I just worry a little bit at the moment with the conversation around integrase inhibitors and weight gain. Certainly a lot of studies are showing that that integrase inhibitors, especially the new ones, can cause weight in people, and reporting that it can be in some Black people, and especially amongst Black women. I just think we need to really be careful when we see this. We need to think about what are the causes. You know, are they social? socioeconomic? Are they due to other biological reasons? Can we predict who's going to put on weight? But I think it's really important that we don't use this as a way of making broad policy decisions. So a good example of this is with dolutegravir and the increased signal around pregnancy defects. We know that some countries banned women of childbearing age from getting dolutegravir. And thankfully that's now been reversed due to a lot of activism. I think we just need to be careful that we don't introduce policies based on the false concept of biological race into HIV care. And we don't say, for example, we don't ban integrase inhibitors for Black women. For example, we need to look further into what are the biomarkers and genetic indicators that may indicate that people may be more likely to put on weight, and then perhaps we need to test them. Either way, we should take this all individually, take the patient as an individual and not introduce broad policies based on possible biological race theories. Next slide, please. So I just wanted to also show this paper that was recently published, so actually published this month. And this is a really great read for anyone who's doing research on how to actually report on racial health disparities. And it makes recommendations for researchers, for journals, and for reviewers. So it makes recommendations on how to talk about race and racism. So if you're going to be looking at race during an experimental design, you need to define it and specify how you're defining it, and also specify the reason for its use in the study. It's important to name racism, which is not always done. People often talk about structural discrimination or inequalities, but don't name racism. And to identify the form, the mechanism by which it might be operating, and other intersecting forms of oppression that may compound its effects. It also advises not to offer genetic interpretations of race, because such suppositions are not grounded in science. So that's what I was saying about race being a poor proxy for ancestry. And it also talks about how important it is to get the input of patients in any research that's being done. So I just advise looking at this because I think it's a useful read and provides some good recommendations. Next slide. So in conclusion, I think it's really important that we don't have a colourblind approach. So we do need to measure differences by ethnicity and race. And by not talking about racism, we're doing our patients a disservice and perpetuating institutional racism. It's important to think about what causes the differences that cause racial disparities in healthcare. And remember that actually it's not a genetic difference or a biological difference. It's more likely to be the effects of racism. So we are measuring racism, not race. And misusing race as a biological category can further embed racial inequalities. We also need to make sure we make treatment decisions based on not on the assumptions of race or ethnicity or stereotypes, but on the individual. And it's really important that we address the socioeconomic inequalities caused by structural racism. And as healthcare professionals, I think we have a responsibility to advocate for this, and we're in a good position to do so. Next slide, please. So I'm just going to end with a list of some things that I'd recommend you read or listen to or watch just to find out a bit more about this. There's a couple of TED Talks there, a few podcasts, and some really excellent books and articles. So feel free to write them down or look at this later. And I will end there. Thank you very much for listening, and I look forward to hearing the questions.
Thank you very much, Rageshri, for that really amazingly comprehensive, but also very shocking talk about race and health. And I think certainly working in the context of sexual health, where we routinely treat syphilis, just realizing the history of where that came from, it's really appalling, really, really appalling. And I think, unfortunately, there are so many examples which you showed us very clearly there. We have some questions coming in. So just a reminder to the group, we have another 11 minutes to go. There's a comments box, or like a speech bubble on the left-hand toolbar if you want to ask a question. And a reminder that this is being recorded, so it will be on the website afterwards if you've missed any of the previous talks. So for Rageshri, it's a good point about scores, but this isn't what you do, but isn't this, sorry, what you do for many groups when using prediction scores. These are always based on populations rather than individuals. And so, say we make assumptions about men versus women, older versus younger people. even though we know that individuals are different. Would be interesting to know if abandoning the race adjustment for EGFR in the US actually results in better or poorer outcomes for the population as a whole.
Yeah, I think that's a really important, because we have to use we have to use shortcuts in medicine, because it'd be very difficult not to. So these diagnostic algorithms are really important. But I think when we think about race, so especially when we think about, you know, Black people, who are Black people, African Americans, who many of these studies are done on, are maybe very different genetically to people from Black Africa, from people in Sub-Saharan Africa or people in North Africa. We know obviously that African Americans, they've been in the US for generations now, and there may be more mixing with people of other ethnicities. So genetically, they may be very different from African Americans. So Black is such a broad category. And it's the way that we define it is by looking at skin color, and, you know, how accurate is that? It doesn't seem very scientific, and that seems very different to looking at age and looking at gender, for example, which we're not just looking at someone's skin. Does that make sense?
Absolutely, particularly as a white Irish person who desperately tries to get a tan. No, absolutely. I think the whole skin color thing is just insane, and I think we need to move away from that really rapidly. Another question has come in, Rageshri, for you, and I think maybe this will take us back to Claire if she's still with us as well. The NHS occupational risk assessments include race as a risk factor for COVID-19, with a higher score for staff who are BAME. This suggests that the organisation believes in genetic causes based on race. Do you want to comment on that, Rageshri?
I don't think it necessarily does. I mean, I think when we look at how being Black or Asian, I've described so many health disparities there already. It's what it doesn't specify is that it's due to genetics. It may be due to all the other things I've talked about to do with racism, so socioeconomic difference, the chronic increase in stress hormones, etc. So, and also what Claire said, just in terms of discrimination within the NHS to do with race. So I think the assumption from the questioner is that it's to do with genetics, when actually it's to do with all the other social stuff and the impacts of racism, which put them at higher risk of getting and dying of COVID.
Absolutely, absolutely. Do we still have Claire online? Phil, are you able to? Is Claire still with us? Hi, Claire.
So I am. Hello.
Thanks for staying with us, Claire, because I know you have to go soon. So, following on from what we've just discussed there with Rageshri, there was another comment that came through early on, and was just talking about the surprise that you expressed at the extent of the difference based on BAME. And I'm just wondering, was that because it hadn't been seen before to such a high extent, or you know, there wasn't necessarily an explanation for it, or what was that? There was just someone just commenting on that we know that BAME health inequalities exist, and so what was different about COVID for you on this occasion?
So it was just that the difference between, if we compared, you know, the deaths we're seeing this year with COVID to previous years, I think it was that difference. I think it was all the differences we're seeing, the sort of differences in the disparities by age, you know, that sort of came. So I think I think it's just really significant. We just weren't expecting. Where there's always health inequalities, and we see it every year. And we're you know, we've got very quite sophisticated surveillance systems, and we know we're looking at decreasing the gap rather than increasing it. But clearly, COVID has increased it, and I think that's shocking. And I think that's what surprised us. So it was sort of it's a very complex, ethnicity and health is a very sort of complex area, and you know, we're trying to identify, you know, what's driving, you know, and it's a multiplicity of factors, and we don't, you know, know exactly how much each is contributing. So you sort of have to work across at all of them in order to make some, to make some gains and positive difference. So I'm not sure that answers your question, but so I think it was not just the BAME issue; it was all of the disparities and the very significant.
And there was another question for you, Claire, and it was, so I don't know who this is from, but it says, I assume the PHE data are using their standard approach, i.e. any death in someone with a positive diagnosis, regardless of when it was. Are the age effects attenuated if you focus on 28-day mortality?
That's quite a technical question. I'd need to go back and have a look at the data to answer that, and I'm really happy to do so for the person that's asked that. But I need to go back to make sure that my answer.
Grant, I'll confirm with them who it is, and maybe if then we could get that answer to
Very
them,
happy
that would be
to,
great.
Yeah.
Lovely. Okay, thank you. So we haven't had any more questions come in that I can see. I think so. What I'm going to do is I'm going to summarise what have been just amazing presentations, just in the breadth of data that has been presented. And I think the experience of the group that we have had here speaking today, it's just been really outstanding, and absolutely delighted with all of our speakers. So thank you so much. So I'm going to summarize, and of course now I can see all my typos, even though I did check this before I sent it in, so apologies. I don't think anybody else had a single typo in any of their slides. So in summary, Clare's PHE analysis of COVID-19 showed increased risks for dying from COVID, specifically age, especially if aged over 80, being female, living in more deprived areas than those living in the least deprived areas in the UK, or in England, being from Black, so being from BAME groups versus white ethnic groups. Rageshri then showed us in the context of medicine that racism in all its different forms kills, and this is true in real life, as in non-medical life as well. Researching race and ethnicity are important so we can recognise and address health inequalities, but race is not a biological category, and I think Rageshri has shown us that in abundance, the evidence for why that is. And so using race in research, we need to justify why we're even asking the question, and is it racism rather than race that we are looking at? So we need to be very careful there when asking those questions, and also interpreting research that give race as a variable. And then finally, summarising from Sarah, as I think this really encompasses a lot of what we see in HIV as well, in that individuals from BAME communities suffering from mental health are not hard to reach. And this is something that we have experienced in HIV, with trying to reach out to vulnerable individuals. It's actually us, it's the services, so mental health services and clinicians, that are failing to provide adequate access and support. And I think particularly Sarah's talk has given me a thought that empathy is not really what we need to have. We need to have culturally appropriate empathy. It's not about our experience and what we project onto somebody else and what they might be feeling. We have to understand cultural context from which somebody is coming, to understand really what help we need to try and give them, and how to support them properly. So we are coming to the end of today. I just once again want to thank our amazing speakers for all their hard work in putting this together at such short notice. Rageshri, who was the leader for this symposium, absolutely amazing, Rageshri, thank you so much. And to Sarah and Claire for just fantastic talks, just really, really amazing. BIVA, thank you so much to BIVA for sponsoring this podcast, and for allowing it to be filmed, and for our speakers for agreeing for all the speeches to be recorded, or talks to be recorded, so that they can be on this Swift website and available for you to recommend to colleagues, or to watch at another time if there's things you need to watch again. And particularly in the context of the podcast, I'd really like to thank Karen Anthony, who was amazing at pulling this together so quickly, and of course Phil, who has been our support for all of this. So with that, I'm going to bid you all a good afternoon. It's sunny down here in Brighton. I hope it is where you are. And I wish you all a good weekend. But if we put up our last slide, if we can remind you, this is part one of 2 symposia. So our second symposium is on the 11th of September, again from 2 to 4 p.m. And we hope you've enjoyed this, that you'll come and join us again for this seminar, and that you'll recommend us to colleagues, friends, because I think there's a lot here for individuals outside of the HIV world. So thank you so much for joining us today.